Good morning, everybody. My name is Valentin Newhouse. I'm one of the trauma attendings. I'm very happy to introduce Dima Eshmumimov. I met Dima Eshmumimov just recently in the ETH, and we talked about research. He has some fantastic research, Liver for Life, for example. And I'm more than happy that I'm part of this lecture this morning about polytrauma. He asked me if I can assist him, and I'm more than happy to help.
Valentin, thank you very much for a kind introduction. Our hospital is a referral center for patients with polytrauma, and we visceral surgeons are involved in a multidisciplinary team and in treatment of abdominal trauma with colleagues from trauma department. I would like to start my presentation with some sentence with Harvey Mackay, because time is one of the most important factors in trauma setting. Time decides the further course of the patients. And if you follow this slide, you see three peaks of death in patients with polytrauma. The peak happens mostly during the first hours. As a medical doctor, we don't see those patients. They have usually trauma that is incompatible with the life, for example, decapitation or massive extremity loss with massive bleeding, and usually we cannot help to those patients. And second group starts to die within the 2 hours, and those patients are of most interest for us. And then second peak comes after weeks due to immunosuppression of patient and infection and complication of trauma. In my presentation, I will concentrate here because we surgeons, abdominal surgeons, are involved in this part together with trauma patients. Therefore, this is a deciding also for patients for further course, and then it's called usually as a golden hours. And as usually, there is a definition of everything, and polytrauma usually is defined life-threatening injury of more than one body region and organ and system, and the injury severity score should be usually at least 16. And this calculated based on body regions. You see every region has different names, and you can define for every region, give points, for instance, minor, moderate, serious, severe, critical, and untreatable. And you summarize it with this formula, and you can say if patient has a polytrauma or not. Also, I have to say the definition is might be vary, and there is no consensus on definition, but this is one of the most common used definitions. And pathophysiology behind is quite complicated. At the beginning of trauma patients, we have hypoxia, shock, hypothermia, and at the same time they have multiple injuries of bone structures, abdomen, and trauma. All those associated with lack of sufficient oxygen delivery to the organ, and it happens usually within the first hours of trauma. And the main treatment behind it is ITLS in damage control surgery. Afterwards, it comes to recovery slowly, and then between day 5 and 10, we have usually a window for opportunity. After day 10, they start to have second peak, which I showed in the previous slide, because of infection and immunosuppression. And during the first hours of trauma, the key factor is to restore oxygen delivery to the organs. And this based on advanced trauma life support, and it's all of this ABCDA, and all is dedicated to deliver sufficient oxygen to the system. For instance, brain can survive a few minutes without oxygen, heart as well, muscles or kidney could tolerate some hours of oxygen deprivation. Therefore, it's quite important to restore it. We start in a trauma setting with a always examination. If there is any obstruction, it should be eliminated with intubation or with suction if there is any aspiration inside. And the second thing is a pneumothorax or massive hemothorax. In this case, you have to put lines to drain it. The most important thing, if you have a patient with knife inside, usually it's not allowed to remove this knife before arrival. Even in a shock department, usually you don't remove it because removal of any foreign bodies causes bleeding. Therefore, it saves also somehow tamponation. Therefore, you remove it after you have clarified the location and cause. And the third thing is shock. Usually in trauma setting, we have hemorrhagic shock, and it can bleed from extremities. It can bleed in chest, abdomen, pelvis, and long bone structures. The most important thing to eliminate is to stop the bleeding. This is a picture from Boston bombing. You see the patients have amputated extremities and then they are bleeding. The first thing is to stop the bleeding. Quite challenging could be stopping the bleeding from pelvis because the bleeding cause could be multifactorial. It can bleed from bones, it can bleed from venous injuries, it can bleed from arterial injuries. And venous injuries and bone injuries, you may tamponate. However, before your tamponation, you have to fix pelvis. Otherwise, putting all these gauzes could not help if bone structures are destroyed, and then because they cannot compress anymore and give pressure. Therefore, first you have to fix it, and then afterwards you go and then put gauzes for tamponade. However, this can stop only venous bleeding or from bones, but it cannot help to stop arterial bleeding. Therefore, if there is arterial bleeding in patients with pelvis injury, you can go for interventional stopping or surgical ligation depending on localization, and angiography might help to identify the cause of the bleeding. We are, as a visceral surgeons, involved in treatment of those patients, especially in abdominal trauma setting, and we operate together with the colleagues from trauma department. In abdominal trauma, we have to define priorities because there is two approaches depending on patient's stability. If you have a unstable patient with hyperthermia, acidosis, and high lactate and coagulopathy, and the patient needs very high dosage of vasopressors, usually you don't go for definitive surgery. The aim will be in this setting, damage control surgery. If the patient is stable, no inotropic support, and with urine normal output and the low lactate, you might try to solve the problem in a definitive way. And the aim of the damage control surgery in unstable patients is to restore pathophysiology. It means first aim is to stop the bleeding, and aim of the definitive surgery to restore the anatomy. If you go to the abdomen, the first priority is to stop the bleeding, and any spleen injury with bleeding, spleen should be removed. There is no role to save the spleen in a polytrauma setting usually. And for the liver, of course, there is a different levels of injuries. It can be just with a knife, or it can be just blunt trauma. In both cases, the aim should be packing for the to stop the bleeding. And for vessels, you may try repair. For instance, for aorta, it should be repaired, otherwise it will not help. In intravenous cava, if the injury is located in infrarenal part, you may try repair or ligate, and suprarenal usually requires repair. And second priority in abdominal trauma is stop to contamination. In this setting, we usually don't put any primary anastomosis in damage control setting. The aim would be in this setting to just put staples with a complete closure of intestine, or you can just put a diverting stoma. And in a second and later phases, when the patient is stable, you may try then restore the continuity of the intestine. And for the lymph, usually is removed if you have unstable patients, because there is a rule in a polytrauma patients: life before limbs. Therefore, usually we cannot save the limbs, and of course it's quite heavy for patients to survive afterwards. However, may we try to save life and limb together. People have tried to do it. As I mentioned in my previous slides, patients are quite unstable during the first days. Therefore, you cannot put it at the same time. Therefore, people try to keep the extremity with ex vivo perfusion. This paper was published by Teger et al. In Annals of Surgery in 2019 in June. They had 2 patients with extremities injuries in a polytrauma setting. They connected, as you can see here, with a pump and used crystadiol in putting some electrolytes and perfused it for 16 hours, 2 extremities. And afterwards, they connected to the patients. Interestingly, if you see, there is output which goes to the back to the machine, and they could not collect all these fluids from the resection surface. Therefore, they had to use almost 15 liters of fluids. And in one case, the patient was successfully implanted, only upper part. In a second patient, the patient died from a cardiac arrhythmia in postoperative setting. And the second patient had also quite a high infection in this extremity. And looking at all these results, I had a feeling they don't have a specialty device to perfuse extremities, and most probably they didn't talk to engineers, because extremities perfusion should be quite easy, and a system that can maintain extremities perfusion should be not difficult to construct. And you see, this is 1 month after implantation. They had to remove lower extremities before implantation. It was severely damaged, and patient was using this extremity after discharge in outpatient department was controlled. And as you know, our department has submitted a novel perfusion technology for liver perfusion, which can maintain viable human livers for 1 week. And we came up with the idea, and can be also used in a trauma setting. A novel concept would be, if you have an unstable patient, of course you cannot put the extremity back because they don't tolerate it, and then here life is before limb. And you stabilize the patient with ITLS and damage control surgery, and you put the extremity to the perfusion machine. You can preserve 1 week. Let's say we never tried extremities, but the liver is quite complicated organ, and the extremity should be much more easier. And there is a window of opportunity which I showed in my previous slide, between day 5 and 10. And during this time period, you can try reimplant this extremity to the patient. And of course, there is no clinical data, and there is no animal data. We don't know how it will extremity then will function. There is no data, but it's just idea that can be implemented in a clinical setting. This is my last slide, and I would like with this slide to summarize. And time in a polytrauma setting is very important, and oxygen delivery should be restored immediately. This is a primary aim of treatment in polytrauma setting, and life-threatening injuries should be eliminated in a damage control surgery, and we have to define priorities and address them. Thank you very much for your attention. If you have any questions, we may discuss it.
Yeah, thank you, Dima. I mean, this is a topic that needs probably to be looked a bit more in depth. You promote well your work, but I mean, the topic is on trauma today on this, and we're very happy to have Dr. Neuhaus with us. One of the question that we have here, this ATLS is obviously a very important course that I think everybody in Switzerland has. I don't know how it's many other country, but the worst situation is to be on the site of an injury, and we know today everything can happen everywhere. All doctors, at least surgeon, trained to be on the street and be able to do that, because I think that's important that all VCL, whatever surgeon they are, can intervene in that. And I know that in Switzerland the ATLS is done by most other people. My second question here, and maybe speak about Switzerland on this country and about the regionalization. I think this has evolved the trauma over many years, and I think there's strong data now that every small hospital doing trauma is not the best way to achieve that. So we try to have centralization or regionalization for this with quick evacuation of the people. And I think it's also an important topic, particularly those days with what can happen in the world. So maybe a comment about the ATLS training for all surgeon or non-doctors into this to save life, and how we should handle trauma, I mean, polytrauma in a country like Switzerland or other country in terms of regionalization.
Absolutely. ATLS is introduced in the 70s in the United States by an orthopedic surgeon. He had a crash with his private plane, and his wife died and 3 children survived, but because he was a very famous doctor, he was treated very well, but his kids weren't so good treated, so he said that's not possible. And then they constructed the HLS. The HLS is primarily under the auspice of the American College of Surgeons, and is distributed in about 90 countries. In Switzerland since 2000, and we do about 20 courses a year in Switzerland. And nowadays, all surgeons need to do an HLS course. It's mandatory for the Facharzt, FMH. But we also have a lot of anesthesiology guys, and nowadays we have more and more guys from the emergency departments, because the emergency departments are getting, let's say, more and more autonomous, and they also need to have these courses, HLS, ACLS, and similar courses. So while 10 years ago, mainly surgeons and the anesthesiology guys did the course, nowadays it's more broad, also internal medicines and other specialists. HLS is every 4 years, they try to come up with a new edition. Nowadays we have the 10th edition, and it's quite evolving. For example, CT scanner, it wasn't used 20 years ago. Nowadays it's quite usual to use CT scanners. So that's one point about HLS. About the trauma in Switzerland, I think we have a good system in Zurich. I like it. We have officially 12 trauma centers in Switzerland. If you look at the numbers, the biggest 3 centers are Bern, it's Luzern and Zurich. We have the highest numbers of polytraumatized patients. And I personally think we have not enough polytraumatized patients. We are too many doctors taking care of these special patients. If you look at different centers, for example, Chur, St. Gallen, they have less than 100 polytraumatized patients. And I think this should be a little bit more centralized, to be honest, so that really specialists take care of the polytraumatized patient. The first few hours, it's quite easy to treat polytraumatized patient. I think the goal, as Dima said, is try to get oxygen to the vital structures. That's quite easy. That's the tube, that's chest tubes, that's maybe a pelvic binder, some external fixator. But then to stop the bleeding, it's quite difficult. I remember just recently one case was a severely bleeding abdominal injury We couldn't fix it, but Kuno was there, and he could easily fix it because it was a arterial bleeding at the mesenterica superior. And I think that's our main strength in Zurich, that we usually do the basic work. And as soon as it is tricky, the abdominal surgeons are joining us, and together we are, I think, quite good. Our survival curve is getting better and better. If we compare the survival rate about 15 years ago, it was 15% or more. And nowadays we are getting lower and lower, and I think that's part of the system. That's the CT scanner which helps, that's the teamwork stuff, that's also anesthesiology and intensive care unit which are getting better.
Thank you very much for the presentation. I have one question concerning penetrating abdominal injury in a stable patient, because we had this discussion also in the emergency department, and I would like you to comment on that.
Now, penetrating trauma is very interesting. I had the chance to spend 1 year at the Grote Schuur Hospital in Cape Town, and the main goal at the Grote Schuur Hospital is to treat penetrating abdominal trauma non-operative if possible, because otherwise they are overwhelmed with patients and they couldn't handle everything. So they really try to focus on a few things. They clearly say that with a penetrating abdominal trauma, as soon as a patient is hemodynamic unstable, that means that the systolic blood pressure is below 90 and heart rate is above 100, and you clearly have the penetrating wound or the retained knife in the abdomen, then you need to operate on a patient with a trauma. Second point is the peritonitic patient after trauma, which is a little bit more difficult, I think, to see how a patient is peritonitic. Omental or organ evisceration is usually is a clear indication to proceed with laparotomy. Bleeding from the stomach or anal or vaginal after a penetrating trauma is also an indication to proceed with an operation. I think some indications are quite clear to proceed with an operation. In the gray area, for example, also having a little bit of air in the abdomen wasn't always an indication to proceed with a laparotomy in South Africa. If we had the chance to do a CT scan and there was air in the abdomen, however, the patient was stable and no peritonitic abdomen, we didn't proceed with the diagnostic laparotomy. Because sometimes it would be just a non-therapeutic laparotomy. It would be a positive because of the air. There must be a penetration of the peritoneal layers. However, maybe no significant injury inside the abdomen which needs to be treated.
If we look at our history of traumatology here, which goes a long time with some tradition, it seems that the single most important factor in saving life was CT scan. In the emergency room. Is now the world standard is that most of these patients, unless of course they are very unstable, should go quickly to the CT scan and then from that basis do the priority?
There are quite a lot of studies, retrospective studies, showing that a whole body CT scan is helpful in lowering mortality. Have the patient door to operation have a low time. Be faster, and we think being faster is more advantageous for the patient. However, there was also one prospective study published in Lancet showing that the CT scan didn't reduce mortality. So more studies need to be done. However, we think with the CT scan we have much more information. Also, if a patient needs an operation, we clearly see the kidneys, how do they look like? Do we really to explore this area or not? How is the liver injury? How is the kidney injury? I think it's helpful.
But I think this Lancet paper, which was the problem is that the CT scan was not in the emergency room, there was a huge delay. So here we are comparing apple and orange, a strategy and no strategy. I think there's a difference. We were a lot of time, and it's pretty obvious if that's the case, you waste time. But if you make this diagnosis with this quick CT today, I think this is our policy here to do this CT scan in every patient. So I think this data from the Lancet is not very convincing.
Do we even go to the CT scan with unstable patient? Like what do you define, or when do you say you go to the OR, and when do you prefer to still have the CT scan with an unstable patient?
There are a few indications not to proceed immediately with a CT scan. One is if the patient really has an airway issue. It's a noisy breathing. If the saturation is very low, meaning below 85, 90 we usually tolerate, but 85 it's too low. Then we need first of all to evaluate the chest by a chest X-ray or an E-fast. Then probably put some chest tube in to get the lungs fully inflated. The circulation is more and more, let's say, we just need a line where we can give contrast dye, and the circulation needs to be quite low that we do not proceed with a CT scanner. If the BP is above 80, it's okay to proceed with a CT scanner. Because we lose time sometimes doing chest X-ray, pelvic X-ray, E-fast, and then sometimes it's not 100% clear what's going on. Then we do a CT scan, so you lose half an hour, which is dangerous for these patients. Because, as Professor Clavian said, we have a special situation in Zurich. The CT scanner is really just 2 meters away. So we really try to get the patient immediately from the stretcher, from the paramedics, to the CT scanner, do the CT with a standardized protocol, and get it to the theater. I think that's quite good. And also, to be honest, it's we are very fast with all the specialists, for example. If I remember the last case, it was 5 to 10 minutes and all the specialists are around. Meaning neurosurgeons, abdominal surgeons, trauma surgeons.
I have a comment regarding your statement about the free intra-abdominal air, and maybe just for the younger colleagues for clarification. I think the Zurich algorithm still incorporates a mandatory laparotomy or at least laparoscopy on any patient where we detect radiographic free air. And I think that just should be stated. My question is, what is the ATLS position on minimally invasive access to the abdominal cavity in patients that are being treated at a large trauma center where there's expertise available? Because ATLS has always been a very defensive, very traditional society that has not promoted minimally invasive techniques.
Now, ATLS, it's quite, let's say, political. HLS tries to present one safe way, which is valid in Ethiopia and Switzerland, which is completely different. And what they say, they don't recommend laparotomy. They recommend a surgical examination and decision making. They used to be maybe a little bit more on the laparotomy side, but nowadays they are changing more and more to a more, let's say, the surgeon must decide, but it needs a surgical evaluation, which is, I think, right. The laparoscopy is, sometimes we do it here, as you said, especially in these cases with a little bit of a look inside, and you do that every day, and then you can treat it. However, in Ethiopia, they don't do laparoscopy, so it doesn't make sense.
Okay, good.
Thank you.
Thank you.